Says 9 o'clock. I wish to welcome all members, all officials and all guests. And I've been informed that the Western Cape Provincial Minister of Health, Minister Noma French Mbombo, is also joining us. A warm welcome to you as well, Minister. Welcome to our Standing Committee on Health this morning. I just wish to remind members of the cardinal rules of the WCPP with regards to online engagements. And I therefore now ask that all members and officials kindly mute themselves and turn off their video cameras. I also wish to remind members that in the right-hand side, the chat function, that you please only use the function to draw the attention of the chairperson or to point out a point of order. You are most welcome, members and officials, to kindly turn on your video as well as your audio should you address the chairperson or address the meeting. I will now afford all members and officials and guests the opportunity to kindly introduce themselves.
Good morning, Chairperson Regan Allen.
Good morning, Chairperson and everyone. Van Rachel van Voegel.
Good morning, Lorraine Botha.
Good morning, Chair. Melika Club.
Good morning, everybody. This is Eugenia.
Eugenia.
Okay.
Have we dealt with all members? Eugenia, can you please just indicate your position in the department or whether you are a guest, please?
Okay, I'm a guest. I'm Eugenia Sudumo. I'm from the Rural Health Services based in Mossel Bay. Thank you.
Thank you so much and welcome to you as well. The officials.
Good morning, everyone. My name is Karine Bester. I'm the District Manager of West Coast District, based here in Malmesbury.
Thank you very much.
Good morning, Chairperson. Dr. Chaim de Vries. I'm the Medical Director for the Emergency Medical Service.
Good morning, everybody. My name is Charlene Goliath. I am from Metro Health Services, Department of Health.
Any other departmental officials present? Not. Members, are there any apologies? Also, a warm welcome to our procedural officer and to our WCPP support staff. Members, the purpose of the meeting is to get a briefing by the Department of Health on the safety protocols of the emergency medical services in the province. And in addition, the department is going to brief the committee on the school health and mobile health services within the province. Members, if it is in order with you, we know that officials also have other business to attend to. So once a presentation is done, we will then immediately go over to the question and answer session, of which after that, the officials responsible for that specific presentation are welcome to excuse themselves from the meeting. The department can now indicate as to with which presentation they will start, and I will now kindly ask you to proceed, please.
Thank you, Madam Chair. Emergency Medical Services will go first. So with your permission, if I may share my screen.
Absolutely, thank you.
Thank you.
Chair, sorry, was is sharing the screen. Good morning, everyone.
Good morning, Minister.
I'm French Mbombo, the MEC for Health in the Western Cape. I will switch off my video and then I'll take the questions together with the department then. Thank you, Chair, for highlighting that the questions must be aligned to the presentation so that the other one can be able to live because they are not coming from the same directorate. Thank you.
Absolutely. Thank you so much, Minister. Please proceed.
Thank you, Madam Chair. Thank you, Minister. We've been tasked to brief on the sorry, my slide, just get this right. On the safety precautions for emergency medical services, if I could request, can you confirm that you're seeing my slideshow? It should say format at the top.
Confirmed. Yes, we can see. Thank you.
Thank you very much. So the format for this presentation will go through the early response phase for COVID. We'll talk about better IPC, some engineering controls, before we deal with the meat of the presentation, which is around the impact the impact of safety concerns on EMS, which includes, for the purposes of COVID as well as the staff attack. And then a final word just quickly on community partnerships. So I think the interesting thing about COVID, for me, is how it has shifted and changed our understanding of safety, particularly staff safety, over the course of 6-7 months now. And that is quite something for coming from an organization that has thought long and hard and very engagedly around safety for the last probably 7 to 8 years. And perhaps also just to add on to that, what we found in responding to issues of safety in relation to the pandemic was how those mechanisms and systems that we've put in place prior to in addressing the safety concerns around staff attacks also came into play and were drawn upon in preparing for the pandemic. So I've taken the liberty in this presentation to include infection and OHS concerns related to the pandemic in my framing of what it means to keep EMS safe, as I think that's probably what are also upmost in the members' minds right now. So just briefly about what our initial response was. As EMS, we were probably one of the first to respond to the pandemic. Our preparation actually started in January when words of what was happening in China started coming through the disaster management and disaster medicine circles. And so the picture that you see there on your right is one of the training that we'd done as early as the end of January. And this is part of the problem later on, which we'll get to. The other part that we did is, because of our infrastructure and expertise, we established the Major Incident Contact Center. In the early part, this was integral to responding and preparing the health platform for response. These were staffed initially by medical students and so forth, but ultimately by our college staff later on. The other strength we drew upon was our computer-aided dispatch. So we were able to automate workflow, capture details of callers electronically, track their location, which were quite key again to monitoring the movement of the infection in the early days. Also, obviously, emergency control center training, because again, the public were obviously concerned about this. A lot of information needed to be disseminated, and the call center was one of those places. As part of our initial response, coming from the China analysis, we had dedicated retrieval teams. So we had ambulances that were kitted out exclusively for the transfer of patients under investigation and confirmed COVID positive patients. And this was coordinated from our control center, and this ambulances responded from the Pinelands depot under the auspices of our rescue technician. And this was fine for the initial phase, as we had cases 1 or 2 being identified, and so we were able to manage that. As the pandemic spread, this became inadequate, and so we needed to scale up our responses, and we needed to approach an all hazards approach. Also key, and I don't mention it enough, but I'm certain the members have been addressed many times on it, was the department's policies, its provincial regulation guidelines, and this formed the cornerstone for much of our response and preparedness as we move along. And at the bottom of that picture is just one of the is an extract from one of those documents around safety and the type of safety needed for emergency medical services. So one of the big issues was around PPE, and at the time, particularly towards the end of March and run up towards the lockdown, with global concerns around the shortage of PPE, and this was not missed by our staff and providers. So there was a heightened awareness of the need to ensure that PPE levels are adequate. Fortunately for me, this was not something I needed to think about too much in terms of how we get PPE, as the department had already, from a very senior level through the CFO, mobilized its teams to try and ensure that there's adequate supply of PPE. But having said that, there were deep and lasting concerns from the staff around the supply chain and adequacy of PPE. So I just want to take you back slightly to that first picture. As I said, we trained at the end of January already, and at the time there was very little known about the virus out of China, and so it was a belts and braces approach. And so the PPE that we trained our staff on were what we call A60 suits, which were complete suits, completely isolated, much in the same way as those suits used during the Ebola pandemic in much of Central Africa. And so our training was geared towards that kind of vector or that kind of virus. As we learned more about the virus, both globally and locally, it then turned out that we didn't need to respond in that way, and that our PPE standards and guidelines could alter and shift to and still maintain safety. Now, this shift was actually unique in EMS in that we taught them A60 suits at the beginning, and we were the only component on health, obviously, to teach that. And now we were saying mask and apron, and the staff at that time were not reassured by this change in direction, even though it was backed up by good evidence from the WHO and from our local and national experts. Understandably so, staff was spoken. Mr. Taylor, my provincial chief, and I, particularly in the city, spent much of the next few weeks and a half before lockdown, moving between the bases, speaking to every shift, every staff member, around the alteration and around the change in direction and why it was necessary. Having said that, there was still much fear, and the problem of distance, both physical and ideological, was one of the issues. And so my staff and I were not able to see and find one another. Yet at that time, social distancing was not an issue. So whilst we were busy trying to engage around PPE. We had staff sitting on each other's laps in close proximity, not wearing masks, aprons, not sanitizing in those early phases of the response. And so we had this disconnect between what was their psychological fear, ideological fear, and this actual lack of social distancing. Now it's something that we frown upon very much. But in those early stages, it was just part of the indicative of the strangeness of the world that we were engaged in. As a consequence of that, in Khayelitsha on the 1st of May, we had 3 shifts for 3 days, essentially down tools and not respond at all. Fortunately for us, this was spread across the city. The other 3 divisions continued to work. We were able to provide some cover to Khayelitsha for those 3 days through the staff's willingness from the other divisions to cover that. But there was stalemate between the staff and the management teams at that time. Fortunately, it was resolved, and we managed to overcome that. We are still constantly engaged around that, and there's still some legal action from the staff concerning those. But largely, we've not had a repeat of that. Staff were sufficiently reassured. And this brings me to the last point, the call of duty in a time of crisis. And I was always amazed that staff went to work after an attack. We'd have some really violent staff attacks over the 7 years of my tenure. And each time we had suffered such an attack, I was just amazed that staff called on duty, they called into service, they responded, even while their colleagues were suffering and dealing with some extreme trauma. And I was again reminded of that during the time of COVID, particularly in those lockdowns where fear was very high. And we saw, staff take it upon themselves to withhold services in Khayelitsha. But across the city and across the province, we had staff putting their own safety second to that of delivering of a constitutional mandate. And I'm extremely proud of the staff and of the health department for their actions during that time. And I wanted to acknowledge that formally. One of the other things that we did manage to do is the education and training. Again, as I said, some of the learnings that we've picked up prior to COVID were then exploited during COVID. And one of those things was what we call high efficiency emergency training. This was a training module developed here locally within the Western Cape, and essentially revolved around training small groups, 2 to 3 members at a time, through peer training, so either a supervisor or a trainer, in 15-minute aliquots. So prior to them calling on duty, they would receive training for 15 minutes, or 15. In time of COVID, we extended that to 20 minutes, and it would be very intimate, one-on-one in the back of an ambulance. This training technique program called Helping Babies Breathe, and modified for EMS, and we've published some research around that prior to COVID. Why I'm mentioning this is it enabled us to rapidly train 2,000 staff members at a time when the evidence was changing as rapidly. So we were able to do multiple training sessions, for example, the use of nebulizers, or the use of PPE, or decontamination and donning and doffing, that's putting on and taking off protective clothing at your home, which was part of the training modules we had to put out. And these were developed in very quick time during those first few weeks. There were essentially 3 modules: infection prevention and control, IPC, clinical care. Obviously, COVID required us to change how we looked after staff, after patients, particularly how we give oxygen, how we nebulize them, how we protect the airways, and then also decontamination. Contamination was particularly important for staff because they wanted to keep both their patients and themselves safe, both in the ambulance as well as at home. There was a huge concern for family, and so this formed the basis of our training. And again, very proud of the college staff that managed to produce what it turned out to be 4 modules that we were able to train 2,000 staff on these 4 modules separately. So just part of the innovation that came out. Another thing I have to mention was the department's response. It was a great assurance and reassurance we had, knowing that there were experts, and some of them global experts, working on these guidelines. This is just a small sliver. I'm sure you've seen some of these before, but what I wanted to bring your attention to is the inverted triangle. This looks at the hierarchy of controls around occupational health and safety. It's a pretty standard graphic. So the first top levels is elimination and substitution. This is not possible, obviously, during a time of COVID. There was no way of eliminating or substituting the hazard. And then the last 3 deals with engineering controls, administrative controls, and PPE. So I'm going to be dealing with engineering controls, and PPE is what we spoke about earlier. But the administrative controls are an example of what you see here. And this was produced by the department. Guidelines on when to test, how to test, guidelines on adequate PPE, guidelines on what to do if you think that you are positive, how to isolate, how to quarantine, how to treat. And so this meant that we were able to draw quite heavily on the departmental expertise, and gave us a great degree of confidence. And I think I would hope with the staff as well, as we dealt with the hazard. Into that 3rd tier, which was engineering controls. Key was trying to create safe workspaces, and obviously for us, that's an ambulance. So initially, what you see in the bottom left of your corner there, those were the efforts on the staff to seal off all areas for rapid cleaning. So they covered them in plastic and duct tape. That would allow us to simply remove the plastic covering and discard the plastic covering and replace that in order to keep staff safe. And later on, we progressed towards actually building, installing shields, both in our ambulances and our HealthNet vehicles. So these were solid perspex that separated the driver compartment from the passenger compartment in an attempt to build safer workspaces. I must commend GMT for their support during this time, as well as the Provincial Treasury. This was covered entirely, the cost by GMT, and which is substantial because we had to retrofit 260 ambulances as well as about 80 HealthNet vehicles across the province with these perspex barriers that would allow safety from the virus, but also not introduce hazard in terms of driving. And so another indication of just how the government department rallied around a common cause. The other part of the workspaces are actually the stations themselves. So here we can see that we had to institute daily screening of staff prior to the start of shifts. This later became policy for everyone. But in those early phases, we were concerned as to how do we initiate this. One had done was a mobile screening app, which is but participation wasn't great just because we had such a fantastic footprint at our stations. The other part, again in the bottom left and the center of your screen, is the decontamination sites at the station. So these are places where after transport of a COVID positive patient, we would clean the ambulances. They would doff their PPE and don and clean set. This is one of the problems with this was obviously it lengthened our mission time, and so and we see the drop in performance during that time, but it was a inevitable drop in performance as we tried to keep our staff safe. But probably one of the key initiatives implemented during this time was the commissioning of an OHS service, occupational health service, by a occupational medicine medical practitioner and a nurse. And they were instrumental in dealing with vulnerability assessments of our staff, particularly those high-risk staff, those with diabetes or chronic conditions or respiratory conditions that made them more susceptible. And so Dr. Miller and Sister Venter have traveled the province doing these screenings and helping us protect staff, particularly the more vulnerable ones. I think the next slide deals with that. So when we look at the impact of COVID, just to take you through the table, these are the components of all the provinces. So you'll see there's a city component, then there's a rural component, and then there's the support services like the control center, the fleet, and the finance departments. As part of the departmental policy, we did risk assessments on 108, well, on all our staff, but formalized risk assessments through Dr. Miller and Sister Venter on 108 of our staff. These were staff that scored according to our risk rubric greater than 9. And so how you'd score greater than 9 is if you were over the age of 55, if you had diabetes, if you had any other chronic condition that made you susceptible. Then you would score a risk score between 9 and 16. If you scored 16, we would put you on special leave. And if you're less than 12, we would start looking for alternative placements. The next thing, we had 251 positive cases. We are a staff complement of around 2,000, so just about 11% of our staff, 12% of our staff tested positive during this time, and that's an indication of the safety precautions we've put in place, and that's a great. I take that before the lockdown. If you told me 251 staff would be positive, I'd accept that. In other parts, the standard impact on the workforce has been around 30%, so 10 to 12% is great. At the moment, we only have 3 staff members in isolation, but during the last 7 to 8 months, we've had many staff in isolation and quarantine, and some of them even their family members as part of the department support of the staff members, and that's been really great. We had many staff coming to us afterwards to thank us for that. The good news is of those 251, we've had 244 report back to duty, and I'll speak a little bit about what reporting back for duty is. And tragically, we've had 4 staff members who succumbed as a result of COVID. These were staff members in the vulnerable category group. All of them were placed on special leave prior to that. So despite that, they contracted the virus. When we look at these 8 risk assessments, we have 28 of our staff members on special leave currently, not at work. 18 have adjusted duties. By adjusted duties is either they are doing health net transports, where they aren't doing patient care, or they're sitting in the control center. 28 are alternative duties where they're doing admin functions or data functions or manning a staff hotline as part of their duties. And so what we have is 74 who are at work, who are not in the work and have not returned to the work that they've done prior to COVID. Yeah. I'm nearly done, 2 more slides. Yeah, business as unusual. I think, as I said, safety was our biggest concern thinking for the last 7 to 8 years. We had established a safety forum, which was a joint labor caucus and management forum. And this has been really successful in strengthening relationships and developing strategies to keep staff safe. When during the pandemic, the safety forum changed its prerogative and altered its terms of reference, which meant that we were able to build on those trusting relationships as we dealt now with PPE instead of cameras or red zone, or rather not instead of, in addition to. So just a issue with the safety forum deals with the safety issues, projects, workshops, and operations. There's a separate dispatch desk that when you go into a red zone, you will you hand over to a dispatcher and a controller, and they follow you through that red zone to make sure that you are safe and that we can alert the authorities when we need assistance rapidly. Again, it's a collaboration with our other safety stakeholders like the City of Cape Town, Department of Community Safety, neighborhood watchers, and local authorities. What I must say is, sadly, we were at the Traffic Management Center for a large part of this initiative. Unfortunately, in the early part of the response, the Traffic Management Center had an outbreak, and we then took our staff out of the center. We've not yet returned back to the center, which I feel is needed. We need to go back, but for the moment we're running our safety desk out of our control center. But the efforts and the initiative is to try and get us back with our safety stakeholders. I have placed this CCTV and body cams as a point. We are exploring that. There has been some media articles around that. It's still very early phases. We've had some interest from the industry, and the call for body cams has been from the safety forum and from labor in particular. As we've seen, it's successfully deployed in other parts of the world. But it's just in its inception phase, and we'll look forward to seeing what comes out of that. Yeah, and so this is perhaps the disheartening slide. I've put them in this way so that members can, at their leisure, go through the detail later on. But we've had 40 incidents since the initiation of lockdown in March. Prior to lockdown, in the first 3 months, we had 16 incidents of staff attacks from January. And up until now, from the 26th of March to date, we've had 40. Actually, it's 42. We've had another 2 incidents this week. 42 incidents of violence against our staff members. Some of that even during hard lockdown. This is a very concerning trend. Last year, we had a great success in our safety initiatives. where we dropped from 67 attacks to under 20 in last year. And now we're back up at close to 60 incidents, 40 of which were perpetrated during the time of lockdown. I guess it's a sign of things to come. We are concerned as people become more desperate. These are opportunistic attacks, it's our view. They're not targeted at us, but they are concerning. Some of them have been considerably violent, staff being held up at gunpoint. Fortunately, no one severely injured, but quite severely traumatized. Yeah, I mean, I think if there's anything that we should take out of our COVID experience is that there is a need for community participation and everyone being safe, or safety of everyone being concern of everyone. So yeah, I mean, we're constantly working on this. The team are focused on it, and we'll keep at it. I didn't want to end on that note, so I've added the slide. On the top left is my staff vandalizing our ambulances. This occurred during that early lockdown. We're in a quiet Saturday in Mitchell's Plain. The staff took pokers and pens and wrote on their ambulances messages to stay safe and stay in. Interestingly, we had a member of the community see this, and they then sponsored the printing of stickers in the same font. And then what you see in the other slides is our staff taking these stickers and defacing government property in a good way. And I think this was part of just a way of trying to create that sense of community. The department has been talking about this and for quite some time, and we were about to initiate a neighborhood media campaign much along the same lines before COVID hit. And it was really just great for staff to feel that and see them take matters into their own hands and in such a creative way. The center of your slide is the Community Action Network. We've had unofficial engagement with them, mostly through staff being members of their own community action network. And we've seen, admittedly, only anecdotal stories, but staff being able to mobilize through their relationships, resources within the communities, and responses from EMS within those communities, helping out neighbors. And then the last slide was a Facebook post from staff in Mitchell's Plain, from the health facility, who felt compelled to send letters of support out to the staff. I've not put out our minister's dance moves, but those are just part of the initiatives that we've seen being really well received as they take on the Jerusalem challenge, and has been part of trying to just get that sense of team and cohesion going during these very difficult times. So that's brings us to the end of my presentation. Thank you for the opportunity and for the interest. I know we went through and covered through COVID on its own warrants a presentation on its own from EMS, but I thought I'd use this opportunity to speak about safety holistically, and thank you for the opportunity. I'm very happy to take any questions that the members have.
Thank you very much, Dr. De Vries, for your very broad and expensive outline in terms of EMS services. At this point, I think I will want to ask if the Minister have any comments or input that she would like to add to the presentation at this stage. Minister Mbombo.
Thank you, Chair. I'll wait for the questions. Thanks.
Thank you very much, Minister. Members, the floor is now open for you to pose your questions. I think I will have the first bite at the cherry, Dr. De Vries. In terms of instances where staff were exposed, what was the contingency plan for EMS services implemented at the various centers? That will be my questions. Members, can you kindly indicate? I recognize Member Botha. Any other members? Member Allen?
Thank you very much, Chair.
Just one moment, Member Botha. Member Kego, is that the only 3 questions? Thank you very much. Kindly proceed, Member Botha.
Thank you very much, Chairperson. I'd like to welcome the presentation, and I want to say well done to Dr. De Vries, the Department of Health, the Minister, for their supportive response to the EMS team during this time. And thank you to the EMS staff who have during this time stood the test of time. I want to ask on the third last slide, Dr. De Vries, in regard to those staff that are not on full duty and doing other lighter duties, if I can term it like that. How does this impact on those who are in the front line and doing the EMS actual duty? And when will these staff that are now still on lighter duty, how do you monitor as to when they will be fully capacitated to go back to actual duty? Thank you, Chair.
Thank you very much, Member Botha. Member Allen?
Thank you so much, Chairperson. To Dr. De Vries, thank you so much for the presentation. Whenever we hear of a medical practitioner that has succumbed to COVID, you feel it. And if it comes out in the media, and I believe the presentation states 4, my sincere condolences to those staff members. But what I would want to zoom in on, in terms of the involvement and the engagement with communities, neighborhood watches, CPFs, the collaboration with law enforcement. If you are able to give a more detailed, not detailed, but if you can speak to that more, especially linking it back to the fact that we've experienced a number of attacks, and if there's any feedback on what has happened, or did SAPS or law enforcement ever play a key role to ensure that those that are that were part of the incident, that threw a stone, that raised a gun, etc. If there's any cases that's currently pending in this regard, obviously we need to send a strong message. I believe once any person attacks EMS, it borders, in my view, borders on evil tendencies. So is there anything that you can share in that regard, with if there's been any cases pending, or SAPS or law enforcement actually taking action or catching people? Thank you.
Thank you very much, Member Allen. Member Kego?
Thanks, Chair. Let me first commend the department for the kind of handling of the entire emergency services during the pandemic, and especially at the time when we had the epicenter of the pandemic itself. And especially about delivering the high efficiency emergency care training, which was necessary for our emergency workers, and as well as putting the engineering controls, which means installing all those necessary equipment to ensure that our staffing was working under safe environment. Mine is around the issue of Kailicha. I just wanted to understand that what was the impact as far as that is concerned, whereby it is reported that around May there was some kind of a withdrawal of services. How was the impact in that regard, and what is their strategy of dispute resolution because you must check this is an essential service. If people would withhold such kind of critical services at a time whereby they are needed most, what are the mechanisms that are put in place to avoid such kind of situations? But I heard through the presentation that there is a legal action that has taken place, but I just need clarity that who's taking who where, as far as that is concerned, to ensure that such a thing does not get repeated. Thanks very much, Chair.
Thank you very much, Member Turgo. And then I recognize Member Van Vogel.
Thank you so much, Chair. I also want to welcome the presentation from the department. Chairperson, mine is if I can get an answer from the department in terms of the red zones. What is the update on the red zones and how are they going to improve the waiting time for ambulance in the red zones? And as people continue to wait hours for ambulances and we need to improve our services. And then with regards to, Chair, can you hear me?
I can hear you. Please proceed, Member.
Yeah, and then I also need to know how many of these how many of the officials contracted the virus in line of duty, and what measures were in place to ensure safety of both staff and patients. Then the last one, Chairperson, it was on slide 10 with regards to the body-worn cameras. What is the total budget for the initiative and who is paying for this? And what other measures are there to prevent violence from taking place as opposed to other measures that only react to these attacks? Thank you, Chairperson.
Thank you very much, Member Van Vogel. Members, that concludes the first round of questions. I will ask you now to kindly lower your hands. There will be an opportunity for follow-up questions as well. Dr. De Vries, over to you.
Thank you very much, Madam Chair. Wow, great questions. I wish you asked Minister Mbongo first, but I'm going to try and go through all of them, and then obviously we'll defer to Minister Mbongo at any time if she wants to comment. So thank you very much for the well received presentation and your comments around the staff. I wish they could hear you, and I wish that they were here instead of me to receive them, as I think I get them far too many on their behalf. But I will try and convey them to that. So thank you for that. Madam Chair, for your question around the contingency plans for infection. So this was probably in that first phase, it consumed the bulk of our time. To be honest, during that time, my management team and I, it's just a blur. I mean, I don't know. I never knew what day it was, whether it was a Monday or a Sunday, and we never knew whether it was day or night. It just flew into one blur. And one of the big focus areas that we had was on contingency. So there were two areas of contingency that were of grave concern. The first is the obvious one, and that relates to ambulances and crew if they got sick. So when we heard that in other systems there were 30% of their workforce in a service such as ours, that would cripple us, would be devastating. So we needed to look at how do we enhance our ability to respond in resources. So the first thing was the safety of the staff. So for that, we had approached the department and agreed that the public quarantine and isolation sites would be kept for staff. This was a question for the big portions of it would be kept for staff. This was a serious concern for staff during those initial engagements: is how do I protect my family? And so the department were very generous in doing that. And so we had several staff members stay at these facilities while they wait for results. And that made a big difference to us being able to say, we hear your concerns and respond to them. So that, and it allowed staff, I think, to report early, contain the virus, and return early as a consequence. So that was one of the more proactive steps. Later on, as we explored ramping up of the service, we started reaching into our other partnership, and that includes the private sector. So right up front in trying to commission CTICC and the impact that interfacility transfers would have on the city, we had engaged the private sector. I guess in a positive way, the greatest and the most encouraging response was from the small operators, the private sector. The big private sector operators offerings were not that great, but the smaller private sector operators have been greatly encouraging, and their productivity has also been phenomenal. So it's allowed us to offset the 70 staff or the 100 staff that are not on duty, which equates to about 10 ambulances for 24/7, 365. It allowed us to mitigate their absence. So we have seen great efforts on the part of the private sector able to do that, and they were doing that at a cost which was very competitive, and in fact rivals our own cost. And so that's been a big positive in this process, and one that we hope, and had a meeting with the PEXCO yesterday, where it was discussed as a way in which we prepare ourselves for what lies ahead as a consequence of the COVID bill for the next 3 to 5 years. So we've seen that as a great positivity, but it's also helped us as a contingency for the drop in resources. The other grave concern, which is less obvious, is that of the control center. An outbreak in the control center would essentially render our response incapacitated. So so in that initial phases, together with our vendors, we built essentially satellite control centers at 2 or 3 of our bases. That allowed us to close down the main center in Tygerberg, send calls to the rural control centers during that first phase, and then commission, shall we say, cleaner sites or clean sites at the bases, while we deep clean the Tygerberg control center. And we've had to do that on 3 occasions during this time. The first time we did that, there was a drop in service for considerable length of time as we try and establish the procedures. But right now, within an hour, we can have the center fully functional, and the public won't even know. So that's been 2 of our key contingencies: the one around private sector and pulling on our own resources, and the other around establishing satellite centers at our bases in the city. Then the question of how do we, Member Botha's question around those who have not returned to full duty and the impact on the front line. That is, yeah, I mean, I think, again, the commitment of staff is just phenomenal. What I can say around how we mitigate that, how we the impact of resources, is through our occupational medical practice. So what happens is staff have what they call progress reports. So Dr. Miller, either telephonically, will call them, or Sister Fenter will call them. How are they doing? Do a screen in terms of symptom screen, shortness of breath and the equivalent. If there's any concern, they come in. If they don't want to see their own GP, they come into the clinic, and we will test them. And over the infection rate, Dr. Miller and Sister Fenter will return them fit for service. That'll either be full service, or in which case they'll say, look, we've looked at them, they're cardiovascular and respiratory doing really well, they can resume duties, or they'll do attenuated service or amended services. And so Martin will usually tell us and say, look, for the next 2 weeks, we'll watch them, see how they're doing. do some light work, maybe driver work is all that they can do for the moment. And so we do draw quite heavily on Martin and Sarita Venter, Sister Venter, to guide us through that process. And the staff have generally accepted that, well, there's still some mistrust around it because obviously this is from the employer. But having said that, both Martin and Sarita have established a great relationship with the staff. And as a management team, it allows us to make decisions in their interest and in the interest of the public. I do think, though, the question of psychological impact is still one that we're going to see for years to come. It is mental health. This last week, and this was highlighted by the minister. Member Allen's questions around. Thank you for your condolences. Your questions around the neighbourhood and SAPS and the role of SAPS. I'm going to include that. So what we've seen with SAPS is they've always been great in responding. And by SAPS, I don't necessarily mean the high officials. I don't have much opportunity to engage with the senior members of SAPS, but my team do engage very frequently with the station commanders. And at that level, we've just had a phenomenal support from the station commanders, both in SAPS, but as well as law enforcement from the city. And that's been key to us being able to respond to these incidents. During all those 41 incidents, or 40 incidents, the one happened yesterday. Of those 40 incidents on the graph, we report almost all of those cases. If the staff members don't want to report, then we respect that, and there's been one or two occasions where staff don't want to report the case. Either they don't feel it's necessary. Usually it's a stoning of an ambulance, or it's a threatening action. So under those conditions, staff tend not to want to report. But overwhelmingly, 80% of the cases get reported. Of those 40 cases, in the one case, I think was in Khayelitsha on the 25th, where the crew were approached by armed persons who stole their personal belongings from the vehicle. This is rare, it doesn't happen often, but we opened a case at Khayelitsha Side B, and the suspects were arrested after their belongings returned, and they appeared in court on the 15th of May. I don't know what the outcome of that was, but we do try and track these cases. I think many of the cases are stoning, so they're ambiguous. Anonymous. So we don't get a chance to act on them, but we have had great support from SAPS around that, on all things considered. Members, thank you very much for that. I know I glossed over it in terms of my report, and I'll be perfectly frank with you. The Khayelitsha incident really changed how I saw and engage, and my relationship with the staff, and not always in a good way. But having said that, we have engaged openly with them a moment. So maybe just where staff have withheld services in the past, we've dismissed them, and that dismissal stood successfully through the process. So we take the refusal of a response call quite seriously. It's a constitutional imperative, and if you deny that, we consider it probably one of the most severe actions of misconduct. So when 90 of our staff at the Khayelitsha station do that for 3 days, under normal conditions, we would have dismissed them, all of them, because of the severity of the action. However, we would be foolish to ignore the context in which that had occurred. And as a consequence of that, we went an informal disciplinary route. They were issued with final written warnings, which they appealed in the process. And largely they returned to duty. Everyone was reasonably comfortable, returned to duty 3 days thereafter. Where the dispute rests right now is that we informed them right up front that we would the actions are unlawful, we would be instituting no pain, no work, no pay. They took exception to that. There's currently a legal challenge, the fact that we could not withhold salaries. We are of a very different view, and we felt justified in our action. So the members were not paid for those shifts that they were, and for some of them it's 3 shifts, for some of them it's 1 shift. So that's where the matter currently rests, and the only matter still under dispute is the issue of payment. And we will follow the course through that. I must say that, having said that, there was the spirit of it, all things considered, was quite professional, very matured on part of Labour in the way they approach that, or as matured as it can be under these circumstances. So I think all the relationships felt good at Khayelitsha, as considering it being an epicenter and we never had a repeat of these circumstances, I think is a mark of the commitment of the staff and the relationship and leadership of the management. Member Van Vogel's questions. So on red zones, thank you. It remains a challenge. We institute temporary red zones now. We haven't added to our red zone number, and we do temporary red zones because we feel the staff need some sort of sense of protection. So when a staff member gets attacked, as they were in Philippi most recently, we will institute a red zone temporarily for 48 hours. It'll then be lifted and the normal duties will resume. By that we mean that red zone means that you cannot respond unless you are escorted by a police official. So it's quite important that we lift those declarations so that we don't place a burden on police. One of the strategies that have come out of the safety forum is a notion of green corridors. So what we're trying to encourage is, with the staff and Labour, is to move from red zone declarations to the maintenance of green corridors. And what a green corridor is essentially a path, a route into a neighborhood that is deemed unsafe. The neighborhood that is deemed unsafe, but the route that is deemed safe. And these are usually well-lit routes with neighborhood watch or active civic activity in that area. And so we're trying to encourage that. We've had some success of it, particularly in Hanover Park and Heiderveld. And now we're starting to look at those as ways in which to mitigate the actions of red zones. But I agree with you. My concern around the declaration of red zones, I've mentioned before, and I still maintain that. So the team are actively trying to lessen that impact. Infection in the line of duty, all our cases, because they're health workers, are considered infection in the line of duty. So we don't trace them. We don't look to trace them. So if a member of staff gets positive, we consider it a WCA infection. The question of body-worn cameras and prevention, we see that as going hand in hand. You would be familiar with body-worn cameras mostly from the US police system. Body-worn cameras are also used in some of the Australian services, EMS services, and they're more deterrent than a prosecutory tool. And so it was highlighted by Labour, the Safety Forum, as an initiative that they would like to explore. We have had some preliminary exploration of that, and the tender that we published was an attempt to find out what such a program would cost if we had to implement that across a city platform. So that closed very recently and is in the process of adjudication. It's very difficult to assign budgetary amounts to this because we actually don't know. We do expect it to be considerable. And in light of COVID, I imagine there's going to be a conversation around to what degree we can afford that. It might be something that we initiate in certain areas rather than in other profile. But that's sort of the area we're exploring at the moment. So, Madam Chair, thank you very much. I hope I tried to answer those questions. Of course, we'd invite Minister Mbomvu to add her own comments here.
Thank you very much, Dr. De Vries. Minister Mbomvu.
Thank you, Chair. Actually, I don't want to add. I think he has covered everything, but just to use this opportunity because the EMS crew will leave now. just to acknowledge what they do, but what is important is about people must understand that, as we know that in the health sector, we've got different categories of health staff, whether it's nurse, doctors, and EMS. During the COVID, the people actually have been at the forefront. The first contact of a health service has been the EMS. If you look in terms of even when we had our first international cases, it meant that someone has to come and fetch them from the airport. So you can understand that it was the EMS, whether it was in disaster and all of those, but it's part of the package. And the people who were actually most vulnerable were the EMS, because it means that when someone calls you, even at home, to come and pick you up, you don't even know the COVID status of that person. And then the chances are that you have been more closer to that person, because when you pick up on the stretcher and also have to check with the vital signs, in most instances, the mere fact that some of them were very worried for not having the moon suit to protect themselves, you can understand, because these were the first one, the contacts. And then lastly, the other thing that we've seen, I think probably Ms. Bester can talk about that. There's never been any integration that has been quite so obvious between the whole, especially at the district level, the EMS and also and all others in regard to the COVID. Because wherever I go, you'll find that the EMS, yet in most instances, you'll find that they'll be outside the system, not necessarily part of the district hospital or not necessarily part of the district the health management. But the mere fact that they've been throughout, and there's been so much of the working together, the collaboration, especially in regard to in some areas that the pick-up places where the chronic patients have to be picked up, they were compromised. So we want to thank them, not only in participation in the Jerusalem, but also for the sacrifice. Because at least when you go to a clinic, when you are working there as a staff, at least you can see how you can be prepared. But for EMS, there's no other way. Thank you, Chair.
Thank you very much, Minister. Members, are there any follow-up questions from your side? Member Windvogel.
Thank you, Chair. Chair, I just want to check on the staff component. Is there any shortage of staff? And of the staff complement, how many are interns and what are the plans to integrate them into the system on full-time basis?
Thanks, Madam Chair. I think you're on mute.
Sorry, kindly proceed, Dr. De Vries.
Thanks very much. Another great question, Member Van Vogel. I neglected to say one of the mitigation strategies was our interns and our what we call sessional appointments. So what happened again from the department side during COVID was the go-ahead to appoint our interns on contract. Many of their contracts would have expired in that time, and fortunately, it was recognized right up front that we would need them at, that their contracts would expire at the time we'd need them the most. So what had happened, all our intern and contract appointments we've extended up until the end of the year, December, to mitigate the impact that we would have over this time. I must add, and EMS has again, I guess we created these challenges, but we have an intern program that lasts 2 years. And the reason we do that is because they need many skills, not just the medical skills. They also need to drive. They also need situational awareness. It takes them a while to develop those skills. So as a consequence, interns stay with us for 2 years as opposed to normally they stay for a year. And during that time, they develop a strong relationship with the organization and the organization with them. And so the determination of that is really difficult. We have been fortunate in that we appoint about half of our intern groups. And so out of 100 interns that we would get in a year, we would appoint 50 of them. But having said that, we would also not appoint 50 others. And that is just a marker of the financial constraints that we are under. We do try and equip them with skills that will allow them and make them marketable in other provinces and other areas. And I'd really would like to see a collaboration between provinces that would allow us to take these people that we've invested so much in in employment opportunities elsewhere. But at the moment, we've extended them until the end of December, and of those that we have, we try and appoint at least half of them.
Thank you very much, Dr. De Vries. Member Van Vogel, are you covered?
Yeah, yes, Chair.
Thank you very much, Member Van Vogel. Dr. De Vries, I think that concludes our questions and answer session on EMS. From my side, and as members expressed, our sincere gratitude to you and your staff during this time and for the sterling service that you provide to the communities of the Western Cape. Thank you once again, and you must have all a lovely and blessed day. I will therefore now excuse the EMS team. Thank you very much.
Thank you very much, Member Chairperson, and thank you to the members for their engagement and the opportunity.
Thank you so much. Members, can I ask, or the department that will be presenting the next presentation to kindly proceed? I also want to encourage the presenter. You are most welcome to also display your video in order for members to see who is speaking to them. So you may kindly proceed with the next presentation, please.
Madam Chair,
Please
I'm not sure, is it school health or is it mobiles that's next?
Whichever is ready to go. Mobile services is fine.
Ms. Bester, can I go after you?
Yes. Okay, fine, thank you. Honourable Chairperson Philander, Honourable Minister Mbombo, and Honourable members. Once again, I'm Corinne Bester, the West Coast District Manager. I will talk about safety protocols on our mobile services on behalf of Rural Health Services, consisting of 5 districts, namely Cape Winans, based in Worcester, Gardenroute, based in George, Central Karoo, based in Beaufort West, Overberg, based in Caledon, and then myself here in Malmesbury. I'm going to share with you now my slides. There you can see mobile services from Wuppertal, the one on your left-hand side.
Excuse me, Ms. Bester, we are not able to see your screen. Can you kindly share your screen?
Yeah. Let's see. Let's go out. It worked. 8 o'clock. Kyk net gou of me share, and then it lies there. But they said they can't see. So.
Share.
Share.
Supposed to see it.
Yeah, maak uit nie rooi.
Kyk gou daar, klik
Ja.
daar.
Okay.
En
hierso.
maak ek gou daar.
Okay. Can we ask Douglas can assist you just probably just to put it in if you can't? Douglas from my office. Is the presentation that you already sent? So that it makes things easier. Yeah.
Yeah.
Okay.
Ach,
Douglas, are you here? Please share the screen. Oh, there
really
it's coming. Oh, there you are. Okay. Thanks.
Yes, thank you. Okay, thank you. So you can see now clearly?
Yes, we can see. Thank you. Please proceed, Professor.
Thank you, Chairperson. Wuppertal on the left-hand side, as you can see, during winter time, very muddy roads that they need to drive through.
You can put it on the slideshow. On the slideshow.
Yeah, okay. Yeah. There you are.
That's it, yeah. Thank you.
That's it. Administer it now. Okay. And then on your right-hand side, it is our informal settlement in Clywilliam, Kailicha. As you can see, we keep our social distancing and drive through the townships to really bring the services to our people. We are mainly will focus during this presentation on safety protocols, but just give you a background and introduction. We've got 87 mobiles in the rural health services, as I've mentioned, the 5 districts, of which Cape Winelands got the most, 28, and Garden Route 22, Overberg 16, and West Coast 14, and then Central Karoo only 7. I would like to show you that, as I've mentioned later on in the slide, that we continue service delivery through the epidemic. I took the head counts. This is your children under 5, and then your adults or children above 5 and older. And I took the head count for 2020 before COVID started, and it was a total head count of 302,902 people or patients reached during our routes. And this year, when COVID kicked in, April to August, we achieved a 180,000 patients. And if you take the 302,902 and you extrapolate it to those April to August last year's 5 months, it showed that we only saw 8,203 patients less. So really just to confirm with you that we really focus on our farm health services. Just to bring you on board around the service package, it includes the first 1,000-day focus. As you know, we would like to strive to see firstly that our baby and mommy survive, and then we would like to see they thrive, and then they transform. So we are focusing on basic antenatal services on the mobiles, immunizations, nutrition, vitamin A, etc., our family planning, cervical screening, HIV and TB, obviously include our chronic diseases of lifestyle.
Ms. Bester, my apologies. Yes. I'm so sorry for interrupting you. From where I'm sitting, we are still on the very first slide.
Oh, my word. What is it now? Yeah, I wonder if it's not our networks that's not working here. This is now the first, but I don't see the next slide.
Is there perhaps anyone else from the department that can share their screen?
Let's share. Can you see it now? Okay. Can you see now? Background and introduction?
Introduction.
Okay. Background and introduction. Can you see this slide now?
There you go.
Okay, fine. Thank you. So, yeah. Our mobile health services have long been an essential aspect of our rural health services. They are all linked to a fixed clinic and they are working from the fixed clinic. As I've indicated, continuous service delivery through the epidemic or the pandemic worldwide, and as I've already confirmed that we really saw only for the last 5 months 8,000 people less. So no services were interrupted despite the fact that we de-escalated our services in the clinics and only focus on mothers, children and our psychiatry patients and obviously our chronic diseases patients. Advantages of mobile services versus the fixed clinics. A lower number of patients obviously at any time. There is dense populated areas, but also very low numbers, but we achieved to reach them by our mobile services. And then obviously open air, well ventilated waiting areas outside the mobile service. Some disadvantages, delays in getting specimens back to labs. There's a cutoff time when we need to go back to the clinic and the couriers that will come and collect the specimens. So we need to manage our time quite good. More difficult to follow up patients and bring them in to quarantine and isolation sites. In every sub-district, we do have a isolation site, and we got also red dot transport that assisted us. But patients sometimes are hesitant to come to town to the sites. But we try and manage and convince them it's for them that it's better for them to come in. Then just to reassure you, like Dr. Shaheem, individual risk assessments were done for all our staff on the mobiles, in the clinics, etc. And our clients, we've got a checklist screening, and then we divided them depending on the findings of the screening. We divided them then into a cold and a hot stream, where they then, if it's a hot stream, they are going to a testing site. So this is only background, just also to mention to you that our routes are 4 to 6 weekly on the farms. Preparation of our mobiles, as I've said, they are based at the clinics. Cleaning and sanitizing initially done there. Routine cleaning, sanitizing at the end of every day when they got back to the clinics. Minimum required stock consumables were packed in preparation for our routes, and then staff team, only a professional nurse and a staff nurse on the mobiles. They are really competent to see or to be able to render the package of service as I've mentioned in my first slide. Clinical nurse practitioners, they are mainly at our clinics to see also the acute patient. Then COVID prevention on mobile services, our staffing, our personal protective equipment and safety. On our, as far as staff is concerned, our single patient view date showed a 1,441 staff positive. Unfortunately, it was not differentiated between the clinic or the mobile, but only 3 we could link to a mobile, but surely it could be an undercount. But I am convinced that up till now, our staff on mobiles are really healthy, and they implement the golden rules as we know it by now. Masks and other PPEs, all staff were trained in infection prevention control measures, very, very important. No shortages were reported as far as PPEs. Sometimes it was, we were really in a panic, but we managed to share and see and make sure that every district got these PPEs, proper PPEs. Staff all wear surgical masks, and when a mobile was used for a testing procedure, that sister really was full, got full PPE gear. It is now the shield, it's a mask, it is the gown, it is the gloves, everything. What we did in the beginning in particular, when our staff went out to do households, every house they went into to do the screening, and if it was found that this person do have some signs and symptoms of COVID, they sent that person to the mobile unit and not necessarily to the clinic. You know, you don't want unnecessary patients with symptoms to go to the clinic. So, and that is why they said that that a sister then, she was then do the necessary testing procedure. Some mobiles were used also, as I said, roving units for testing. Not all, but some of them. Disposable single-use gloves also whenever necessary, taking blood samples, vaginal examination, removal of sutures, dressings, testing urine. Very, very important to show you that we not unnecessarily let our patient go to the nearest clinic or the hospital outpatient department, but we make sure and see what we can really do for them on the mobile, bring the service to our patient. Other safety measures includes, as you could see my first slide, very muddy areas, and mostly our sisters, female, and we really also see, put them on advanced driving skills to be safe on our farm roads. Collaboration also with farmers to support staff when facing various issues whilst on the route. In other words, if there's a mechanical problem, that farmers also really assist us to phone and make sure that there is communication to their base, and that they can assist the sister as well as with cell phones. Then our client customer care collaboration, patients and clients wear cloth masks. If they do not have a cloth mask, we really issue them with surgical masks. We just now also received again a significant number of cloth masks and filters, and we will issue them prioritized. Obviously, our chronic disease of lifestyle patients that are a high risk for us. So we really make sure that we issue them with cloth masks, but on the other hand, we expect our communities to comply with the correct wearing of our cloth masks, and that is what we also make sure they are doing. Sanitizing of hands routinely done, health promotion, education, your 5 golden rules, and there we've make use of our non-profit organizations that really assist us with the professional nurse coordinators as well as the community health workers to make sure that our communities comply with the golden rules. Chronic disease management support from community health workers in certain areas on mobile routes. We deliver our patient medicine parcels to the homes. Otherwise, the patient also come and collect the parcels from the mobiles. It's two option. Some to the homes if it's old age people, and others would like to come to the mobile to fetch their medicine parcels. In-migration of workers, as you know by now, here in my own district, Cederberg, it's now picking of oranges season, immigration of workers coming from other provinces, etc. We really managed to work closely with our farmers, and we said, if you are bringing workers in on the farms, they are brand new now, please, for 14 days in those days, or in the beginning, it was 14 days in quarantine, keep them, as we call it, in bubbles, that if there is a person coming up with signs and symptoms, we know that it's only in that bubble. So they divided the also the farm where they work, 30 in a bubble, and they are also staying in the same area to be able to really curb the spread of the virus. So I must say that collaboration with our farmers were exceptional, and they also take, you know, grocery lists from their workers, the in-migration people, and they then went to the town during that 14 days to really make sure that they were not spreading the virus if there were someone with asymptomatic symptoms, etc. Social distancing patients waiting to be seen are required to sit obviously 1.5 meters apart on our farms. There's really we work with our farmers, and not everywhere, I must admit, but there is a significant improvement of if we are going out with our mobile units, that farmers make provision that people are really undercover, that they can, you know, in during winter time as well as also during summertime, that they can sit undercover, maybe a small wall, etc. Only one patient in the mobile consulting area with the nurse at any time. So because of a very narrow space within the mobile clinics. Then healthcare risk waste generation and disposal to adhere to our provincial standard operation procedures, very, very important. We at the moment also receive from Occupational Health and Safety, we receive audits. So this is a very important part. Waste separated at point of generation into general and medical waste. General waste is placed in black or see-through bags. So it happened absolutely also on our mobile units. Medical healthcare was placed into red bags in specific cardboard boxes, the smaller one, because we don't have space for the 50-litre ones that we make use of in the clinics. And then if sister is going back to her base clinic, there they dispose of separate waste. Sharp containers, we also do have it on our mobiles. It is for your needles and to put it in there, and cylinders. Then also we try, like for instance, our speculums, when we are doing cervical screening and dressing packs, that it is disposable equipment, not necessary to take it and autoclave, but some of those things like pin sets, etc., we do wash with soap and water after using, and then place in a container, transport it back to the clinic, and there we send it through to the nearest hospital for sterilization. Then also hand sanitizing, availability and regular use of 70% alcohol hand spray by both staff and patients. And we are very strict also before starting work, before touching our patient, after touching any body fluids, performing any aseptic techniques. We, after removing our gloves, put on the medical waste after finishing each consultation before leaving the site. So we are very strict on hands hygiene. Very, very important part of our work. Then stationery and patient documents. handling of patient health documents by healthcare workers kept to a minimum, because it's also, you can get the virus by handling of documents. Where it is unavoidable, like for instance, our pregnant mummies, maternity case records, as well as our mums do have the Road to Health booklets. They're bringing it to the mobile clinics, and then for baby to be weighed, etc. So it's unavoidable that we really handle those records, but we keep it to the minimum. As I've indicated, routine sanitation of work surfaces and stationary in use, no sharing of paints, rurals, other stationery, minimum use of solvents were emphasized. And unfortunately, at the moment, our couches do not have linen on as before COVID, or a pillow. We are not, because of the infection, transfer of infection, and we also, spray the sanitizer after each patient on the couch. Lessons learned, whole of society approach interaction and collaboration have taught many lessons that we could duplicate elsewhere. Really good stakeholder collaboration with our contracted NPOs, with our farming community, our local government, our community safety. They really walk with us in our communities, that are, because we did the house to house, and they walk with us and make sure that we are all safe. Department of Social Development for the humanitarian relief. SAPs also were present. We sent out a week before our routes, which areas we are going into, and they then accompany us as we go street by street. And also then our private businesses. We also work very, very close with them. Also to mention that on the farms, a lot of farmers lately also do have nurses employed by themselves. So we are, and community health workers that they are paying. So we are also working very closely with them, and also wellness centers. So, I wish I could show you some of our videos where not only health staff, but the traffic staff, the community safety staff, everyone were doing the Jerusalem as a team. And this was really wonderful to see how we connected, how we realized during this pandemic that we cannot do it on our own as health, that we do need our stakeholder. And I think after we would like to reflect that we bond with each other, and we got the respect for each other's role, and we could really get together, and it is only to make sure that our communities are better served also in future. So we must maintain this close collaboration with our other sectors as well to taking the services forward. Then must also say excellent partnerships were built with farming communities. I can mention here only for myself, my medical managers in some of my districts, sub-districts, took it so seriously that they've got weekly meetings with the community farmers. And I mean, they said to them, if you are not going to work with us to really make sure that we don't have outbreaks and so forth, I am going to close down your farm. So strict were they. But yeah, it was done in good spirit, and really everyone wanted to make sure that we are not flooded with the COVID virus at the end of the day. So yeah, I'm done with my presentation.
Thank you very much, Ms. Bester. Members, you now have the opportunity. Please kindly raise your hands for your questions. No questions, members? Minister Mbombo, at this stage, is there anything that you would like to add?
Chair, no, Chair, but I just also again to acknowledge and thank the team, especially the workers in regard to the distances and the heat. Whilst at least for them, in some parts, sorry, there's a noise. So whilst in some parts of the province, they might not, sorry, there's a noise, Chair. I have
Thank
to
you,
ask them to
Minister.
keep quiet. Thanks.
Thank you, Minister. Members, can I please ask you to mute your microphones and also just silence your other devices as well? Please proceed, Minister. You may proceed, Minister.
I was saying, Chair, that the noise comes from me. There are people who are working. I'm sorry for that, but I was just saying that with the mobile services, it becomes difficult, especially with the issues of the weather and all of those. But most importantly, because you are targeting in the farming community, where you find that even if you go to that corner of a street on that Wednesday, but it's even difficult for the people to come out because they have to walk quite a distance coming from their homes and then outside to go outside towards the gate of the farm and then to be able to go in that aspect. So that's why, for example, I think Ms. Bester forgot to brag, but there was a time where, for example, around the Petersfontein, where some people who have to have had an appointment to see a doctor on a certain day, but they ended up not even being able to come because of the distance. And then they ended up in partnership, working out with a partnership with the community where they could be able to subsidize for a private transport where at least if you can't come on that Thursday when the doctor will be there, if you have, let's say you have been seen on Monday, come on Thursday for the doctor, you still have got the responsibility to sit with that you come. But you might not be able to come because it's far. So when they have to have this kind of the subsidies for those, and also to acknowledge some of the employers, thinking of the Lutzville again in Matsikama, where you'll find that for their workers, they ended up having some of the clinics, especially for the pickup of the medication and all of those. And lastly, we need to acknowledge the work that has been done in Cederberg, actually, with the whole of community. I'm just adding now, although we're talking about the mobile services, but with the whole of the community, from the local government, with the traffic officers, with everyone, where we ended up Cederberg, surprisingly, at the time of the outbreak, they had fewer cases because of this kind of efforts. So outside the metro, the rural communities, there's no way that you could be able to, run a service as an island. You'll need everyone, especially if the mobile only comes once a week. It means that on other days, if you are sick, you'll rely on the EMS. But if it's not an emergency, you might not even be able to have an access. Because, for example, from the Niveras to the Vredendal, it's easy to pay a return of more than 1,000, which is actually the amount of the grant for those anti-SARAs. So I want to congratulate the team on what they do, and also understanding that actually for them, whilst in the metro we complain for not having shoes, for them they don't even have feet, yet they walk and keep on walking. Thank you very much, Chair. Thank you, Ms. Bester and your team.
Thank you so much, Minister. I recognize Member Windvogel and then Member Kegel. Please proceed, Member.
Thank you so much, Chair. I think I also want to compliment the staff for working so hard under this difficult circumstances. And I'm happy for the input from the minister. My concern is, Chair, is I visited one of the clinics yesterday, and there was long queues. One of the aunts, she can't walk properly, and what I saw is that you were served, doesn't matter the circumstances of your illness. Can't you walk, or can you are diabetic, you can't, whatever your condition was, shortage of staff. And then especially if it comes to rural areas, then I want to know, how do we deal with chronic illnesses in the mobile stations of trucks when you go out? Because I know there's no doctors, there's no pharmacists. How do the department deal with that? And then just to get clarity in terms of the staff complement of these different mobile services. Thank you, Chairperson.
Thank you very much, Member Winvogel, Member Tego, and then Member Allen.
Thanks, Chair. Mine was around the issue of farm workers. Understanding that previously we were accused as a province of transmitting the COVID to the Eastern Cape. This happened especially around the issue of seasonal workers that were coming to our province and then had to go back at the end of the seasonal work. Now, and some of the concerns that were raised is that people didn't have access to be tested before being transported back. Now, it happens especially at the workplace that in the farms, that our people would be situated far away from where the mobile services are coming. So in of which, according to the presentation, you do not have access to those who are at their settlement dwellings. So what would be the best possible solution towards that we don't have to necessarily wait for people to come forward to be able to have access? You did highlight that there is a very good cooperation that you are receiving from farmers, but we all know that in some instances that you are just being presented with what farmers want you to see. So in circumstances whereby people are bedridden and they are not able to come forward to the mobile facility itself. So what is the plan around that you are able to access each and everyone in the dwellings in the farming community? Thank you very much.
Thank you, Member Tego. Member Allen. Member Allen, please proceed.
Thank you so much, Chair. I just had to unmute myself. I just have one question pertaining to let me just go to my note. In terms of the waiting period, if I'm able to understand that once a patient enters the mobile unit, how long would the average time be spending in the unit? But then also B, how long would a patient be waiting outside of the unit? If the department has any idea regarding the timeframes for those two scenarios. Thank you.
Thank you very much, Member Allen. That concludes this question round. Members, you may now lower your hands, please. And between Ms. Bester and Dr. Nama French, you are welcome to address those questions. Please proceed.
Thank you, Chairperson. First of all, thank you for the compliments and the acknowledgement of the hard work of our staff. I am definitely going to send an email through on behalf of Minister Mbombo and the team to acknowledge them, because they do need acknowledgement after a very, very tough year thus far. As far as long queues is concerned and shortages of staff, Member Windvogel, it is during the COVID, I must say that a significant number of our staff were assessed as high risk and couldn't deliver direct contact with patients. So we try and see if we could replace them with agency staff. We were successful, but it was not the ideal. But this was high-risk staff that suffers also from chronic disease of lifestyle, that are high risk, that could not work directly with our patients. Then non-COVID time, it's rural, and we are not only always, shortage of staff is not always a shortage of budget. It is because of recruitment. We cannot convince staff to come and work in the rural areas. So this is an ongoing thing that we are struggling with to really see how we can make sure that our workers, our staff also see it fit to come to the rural areas. And this is where we get into work very closely with our health facility boards, our clinic committees, all those people, to ask also to work together. If you are knowing of a staff member that would like to come out, please let them come out. But so staff shortages is really an ongoing work in progress. And as I said to you, it is really difficult sometimes to recruit the correct, competent staff in rural areas. But as far as the concern around long queues, we are prioritize our acute. A child that is presented with a fever of 38 obviously will be seen first, then older persons and disabled persons. Long queues will now be more challenging because of the social distancing. And we as a team really try and see what did we learn from the COVID that we need to adapt in future. And come up with a new way of rendering services, a new service design. We don't want our patients to come and congest the clinics and sit there. We must really sit together, and we are in a process to see how we can take our services out to our towns and only make provision for our acute sick patient that must come to the clinic, and see where we can deliver the parcels, the medicine parcels to the homes, where we can get together support groups, do the observations in a hall, always confidentiality, privacy of patients, people. This is a given for us. Please be mindful of that. But how we can do things differently. And then we've got, we call it COPC. It's community-orientated primary care. We've got now nurses that are based in the communities to get that link to the clinic and see if she entered into a house and the poor Oma can't walk, that she makes sure if the clinic staff are not knowledgeable about OMA, that she makes sure that OMA will receive what she's needed. So COPC will be the new focus. We would like to see bringing the services out to the towns and only focus on acute clinics to be able to be less infectious because of the congestion of our clinics, as well as to see if we can really not shorten our period that our people are sitting in our waiting room. So, Member Windvogel, we are on a constant basis working towards this, because it is complaint. We do receive complaints of our communities around this, and we work together to see how we can really focus on this long waiting times and to only get a patient to come and wait for the sick monthly or the chronic medicine. No, the person must not come to the clinic. We must deal with them in a support group, in a hall, in the community, or home delivery if OMA can't get to a clinic. So we are really, thank you for this question. We are really, I can guarantee you, this is one of our priorities. This is one of our priorities. Then, Member Sego, the in-migration I alluded to in my presentation. We call it in-migration. We don't want to, call them seasonal workers, because if they are coming into our communities, they are part of us, and we are responsible for their health. So there are very close relationships with our farmers to almost also to say, what is the right time that we can come to your farm so that you can release your people, that we can look after them? Because our experience is that our people that is coming from other provinces are sometimes very, very sick people. They suffer from HIV. They've got a very low count, CD4 count, in other words, infection. They are not immune, and we must work them up. And also TB, very, very important. So, and also diabetes, hypertension, we find that very young people also suffers already from hypertension. So we are really, we've got wellness centers, we've got our community health workers, as well as our non-profit organization that is working in close relationship with us on the farms to really pick up on those people. And we also, there's an effort to also try and see if they can get us a address in, for instance, in Eastern Cape, that we can contact that clinics there to really try and see on which medicine was this person, or if they can't, then we start from scratch. But we really, they are part of our communities, and that is why we talk about in-migration. And we now discover also that because of the farmers, in Citrusdal, Minister mentioned it there, it was orange picking season from April to October, but then farmers also coming on board with other varieties of, say for instance, I mentioned now tomatoes. So a lot of those people are staying behind. So we've got them on our record, and we can follow them up as necessary. So bedridden people, we make it so easy. Doctor must review the prescriptions after every 6 months. And I can tell you, sometimes if there is a problem, we call the ambulance to get OMA to the clinic that doctor can see Oma and rewrite her chronic script. So we are really, you know, we try really to make sure that we are addressing our community's needs, but not by far ideal, but we strive to improve on a daily basis how we are rendering our services to our communities, because they are very, if we are working with them and offer a quality service, then they are healthy to be able to, you know, to do a wonderful life expectancy, etc., etc. So we are part of all those holistic approach to our people. Then member Ellen, thank you for that. The insight in the clinic, staff nurse is doing the observation. So sister is, you know, taking a short history, examine the patient. So it is 10 minutes basically, because she's got also she's bringing from the clinic, if there's chronic, they do know the patients on the farm routes who are suffering from a chronic disease. So they are bringing the parcels with them, the medicine parcels with them. So they've got it there. It's not necessary for the patients to go back to the clinic. So they are, and outside, it all depends on the density of the farms. In Citrusdal, for instance, there are up till 150 people on a farm. In Broodkraal, near Piketberg, in-migration workers coming 3,000 people at a time. Then we are organizing that we are getting in sessional sisters that is working only for that period of time to assist those people. But also I must say that we are talking to the farmers. They are also employ private sisters and sessional doctors to also do the acute, to assist us with rendering a service to our patients. So here, for instance, in Korenberg, there's appointments from 10 to 12, then Broodkraal's people will come and sister will see between 10 to 12 those people, so that they can go back to Broodkraal. So we, it's not blanketly rolling out to everyone, because you must also remember that circumstances differs from one area to another. So we try and adjust accordingly at the end of the day to benefit both how we can render the service as well as the patient. So I hope that I could answer some of your concerns, and thank you very much for this. I will take it back to our teams again.
Thank you very much,
Chair.
members. If some of you, yes, Minister.
It's important to talk about the issue of the staff. Whilst Ms. Bester has alluded to some parts of it, it's not only about attracting the people. Just making an example, who would want to work in Klebrand or in Redport unless you are from there, that side? So one is to look at that part of it. But what is important is about health can do as much as they can, but the other sectors has to also beef up. Even from the national side, just making an example, long time ago, people, because there are no public transport in any of these areas. I'm just making an example of the Maxikama. Long time ago, there used to be a train, I think once a week, that would be coming from the Northern Cape, and then it passes through the Neervlakte area, and then it goes to the Kukenap and all of those coming to the Cape Town. There is no rail anymore. If you have been to that Morsvlei, where you'll find that the road, because the last time that I was there, I said, I'm not going to come back again, but I ended up going back. You can't even drive because the whole dust covers the whole of your car. So whose responsibility is to fix the road? See the back, the Wuppertal side, that road where you have to go up the mountain and then go down the mountain. Do you know although that we ended up extending to have full-time doctors, for example, in Wuppertal clinic, but do you know the issue of the issue related to the safety, especially if you are a female doctor and you have to drive, because it means that if you end up having a tire puncture, you'll be there forever because there's only one car that drives probably once a week in that area, unless you'll be coming from town and then going to work, let alone the road that have been quite messy throughout. My point, if there could be public transport that go to that side, so if you could push the economy that side, it will mean it will attract for the people to go and work there. And even with the CEOs or the medical managers in some of these hospitals, they are there because they are staying there. They've been there. They are born there. They've been born there. But very few young person, when you have graduated and then you still want to still be staying in these kind of the areas. So the issue is about how does one attract them. So it needs other various ways. What is the role of the municipality to improve those roads? I'm just making, as I made an example of the Klebrand and the report and also the Wuppertal. Now in health, you have a clinic, let's say a station clinic, and then within that clinic you have satellite clinics. The satellite clinics, they also could have a mobile. So when now this clinic, let's say Petersfontein is a main clinic, and let's say they've got 6 mobiles that are attached to it, it means that a nurse will go on Monday to Farm A, which is quite far, 40 kilometers. And then that same nurse on Tuesday must go to Farm B, far. And then the other nurse goes to Farm C, meaning that on the day that they are all away conducting the satellite, it means that that one that is there, of course, there'll be fewer people. Hence, she was alluding to the issue of the importance of appointments, but also of making use of the community health workers, because they don't have to come there. They might be there in community in that Farm A and Farm B. So, colleagues and honorable members, we have to make the point that other sectors have to invest in those areas. And the more there's economy in these areas, the more we can pay far lesser expenditures, especially for the per head count on health. I used to make an example of the Mosselbaai versus Hessequa Kanaland. It's the same district, but you find that you pay lesser per capita in Mosselbaai because of the Petro SA and the movement that is there compared to where you have to pay more to bring services, for example, to Kanaland or the Hessequa. Thank you, Chair.
Thank you very much, Minister. Member Vogel, I will make the following ruling. If you have a new question now or follow-up question, I will kindly ask you that we deal with that in our resolutions. And my reason for that is we still have another upcoming presentation, which is the last one. But we also have quite a few of meeting documents that we need to work through during this meeting time. So can I please ask you to address your next question at the time when we do our resolutions? Is that fine with you, Member Van Vogel?
Yes, Chairperson, that's fine with me. Thank you.
Thank you so much, Member. Mrs. Bester and your team, thank you so much for availing yourself this morning. Thank you for the incredible work that you do within this province through rough terrains, not very conducive conditions at many times. We see that you've built valuable, great and excellent partnerships within the more remote areas, and that is fantastic. Please convey our sincere gratitude as the committee to your entire staff, and thank you so much again for the wonderful work that you do. And we wish you a happy day further, and we will now excuse you. Members, we will now take a comfort break, and we will be back at 12 minutes past 11. Can I please ask members not to log off completely, but do silence your video and your audio. We will be back at 12 minutes past 11. Thank you so much.
follow up on the cases that we referred. Now, I am going to focus mostly on the service that we render on mobile buses. And this mobile, the department contracted a service provider by the name of MST to give us their mobiles. So rural was given 3 mobiles, metro was given 2 mobiles. And these 3 mobiles for rural, they service 4 districts besides the 1 district, which is the Garden Route district, which is an NHI pilot site, which also has their own NHI resources. So it's the buses, the 3 buses rotate between the 4 districts. Now in the metro, the buses focus mostly on oral health services, where the oral hygienist will render preventative service, and if there's any promotional talks that needs to be given, she will or he will give it, and if there's any referrals, then he or she will refer the learners to a fixed facility. Their eye services is rendered by community health workers and a private provider. It is mostly not on the bus, it's off the bus at a certain facility. So the acute and other services are delivered for the learners at a healthcare facility, because most of the healthcare facilities has about a 5-kilometer radius that they service, so they usually are within the catchment area of a school. For rural, we have on the bus, we render primary health care, oral health, and optometry service, because the bus is divided into the 3 compartments. And then we have a professional nurse, a community health worker supporting them. At times, some days we have a dentist on the bus and a dental assistant. But most of the time, the oral side or dental side of the bus is manned by the oral hygienist. And then in last year, we had some funding, so we could contract an optometrist to manage to go onto the bus and do the testing of the learners, the eye testing of the learners. And then we also have brushing programs at either preschools or creches that we run. This is more or less, because this year we couldn't really render the service, so we thought that maybe we should just give you an idea as to what kind of service we render and what we do at school. So this is the 2019 stats that we decided to share with you. As you can see, that mostly our target is the grade 1s and the grade 4 and 8s. But in some areas, we cannot reach out to the grade 4s, neither can we reach to the grade 8s in some areas because of the capacity that we do not have. In some of our facilities, the nurse in a facility will be the one who's going to render the school health service. But in some areas, we have designated school health nurses. If they go on leave, then somebody else from the facility will be taken out, and then they'll have to go and render the service. But we do not turn away other grades. And if there's capacity, we add to in seeing the other grades as well. The preventative service that we render, here we didn't give you the HPV stats or learners that were targeted, the girls that we targeted for HPV. But these are the preventative service. We, as far as possible, we try and do immunizations, mostly your TDs at 12 years and 6 years. And then we screen the learners also. We look at if they are underweight and how can we best refer them or ensure that their weight is being addressed. And then we do the deworming as well. If the learner has missed some immunization, then we refer back to the fixed facilities. Learners referred in 2019, as you can see, the bulk of the learners referred is those learners who present with oral health problems, together with those who are having eye problems. So we do have the oral, the dental team on the bus and off the bus. And then we do have sometimes the optometrist on the bus. But any services that is not rendered on the bus, we ensure that that learner gets referred to the fixed facility to receive that service, or the private optometrists that we contract, we refer the learners to them, and then they do the testing. We do the screening for the eye, and then they will do the testing and prescribe spectacles, and then they will do the fitting of spectacles, sometimes at a very low cost, like the mother or the parents are asked for an amount of 150, but the rest is being taken care of by the department. This is just an idea that we thought we should share with you, and this is the stats only on the mobile, and it's only at selected districts where, for example, your optometrist, last year we only had 2 optometrists servicing 2 districts. So this is not to say that it is for the whole province. It was only in a rural area in 2 districts, and because we got funding for about 3 months, and we thought that since we have funding, let us fund for an optometrist, and then the optometrist can go onto the bus. So they managed to test 3,595 learners, and about 489 was issued with spectacles. Again, I just want to stress that this is a very fraction of the number of tests and spectacle issue that we do in the province. Fissure sealants, we managed to do on the bus. The oral hygienist managed to do about 10,500 fissure sealants, and then we do some polishing as well. We do fluoride applications, and in some areas where the dentist is on the bus, we go for extractions because of, like Mrs. Pester mentioned, the distances. We have a lot of learners who cannot really, whose parents cannot afford to have them now go to the clinic and be transported back again and go back again to the clinic for a follow-up. So some of these services, we reach out to the areas that the learners stay. During the COVID, because it was a quiet period, we focused on staff training of our mainstream and special schools, because we are partners. So as far as possible, we shared information, we trained, because we assume that we are the specialists when it comes to preventative, prevention of infections So our focus was on training, and we gave information around infection control and prevention. And we did a lot of screening as well. Towards the latter end of we are still under lockdown, but towards the latter end when there was some lifting of oh, I forgot the term now, but at any rate, so we help with the screening at schools, because as we all know that after June, then the learners started to come, and then they were stopped again, and then they came again. So as far as possible, we supported in the screening process, but we offered our tools, and if there was any need to explain the tools, then we were available. We developed guidelines for DSD and the Department of Education so that they can kind of understand what we can do and what they can do and how to do the preventative measures as far as COVID was concerned. We had several outbreaks. The recent one was in Central Karoo. So we had to now pool some of our resources out of the community and in some of the facilities to go and kind of combat that outbreak, and we managed to deal with the cases accordingly. Currently, we are looking at catching up on the immunizations that we couldn't do during the lockdown. That is, the staff are now starting to ensure that, you know, learners are followed up with their TDs immunization, which is not easy because, as you know, not all the learners, for example, not all the 12-year-olds will be at the school on a date. So some of them will be the next day there, and some of them, you know, they alternate. So we are trying our best to ensure that especially the immunization must be given to the learners. Like I said, if as far as possible, some of the services and the services that needs to be done are rendered at primary health care facilities. Now, these are just the sponsors that we some time ago we had and we are currently having, and I thought I should just share it with you. A very long time ago, 2015, we had Nedbank sponsored a bus for us, and then also gave us not only the consumables on the bus, but they not only sponsored the consumables on the bus, the staff were paid by them, and then that is a service that they rendered on the bus. Currently, we are having also DISCAM supporting us. We have 2 professional nurses. Unfortunately, one of them is at their Cape Winelands store because there's no school health service. But the other one, who is in Wuppertal, they have agreed that no, she can render primary healthcare services. So it's like it started as a 2-year sponsor, which was extended, and now it's like a 5-year sponsor. And they also sponsor things like your dental wash, the body wash bottles, the dental packs. National also gave us dental packs. I previously mentioned that we had some funding for optometrists, but also Vodacom sponsored us with the payment of spectacles, and the Ackerman Foundation via Health Foundation sponsored an optometrist for these 2 districts that I mentioned previously. And then all what is expected from us is that at least their staff, like the DISCAM, when they work in in the facility, they wear their uniform with their logo. And maybe some of you have seen these buses, these huge buses. They have the branding of some of the sponsors. And last year, towards the end, for 3 months, we had in the West Coast area, we had a religious group who sponsored us with a bus and staff, and they, we welcomed that. National Department of Health, what we have this Be Wise Health that we encourage the learners to it's an app where you can ask questions, any health related questions, and there you will get the answers. And the service also is available to the learners, because you can even get a doctor calling you back within 48 hours. It's something new that it was tested on in the garden route, and that is it will be very good for the learners to explore. Department of Education, as far as this is an integrated service, is helping us with, as far as possible, not with all of our cases, with psychologists and social workers, because we also have our psychologists, but not as far as possible. We are trying that the learners, if we pick up any learning problems or any physical problems, that we refer them accordingly, either to education or to DSD. And we make use of NPOs to support us with the school health program. The PN usually needs assistance, then we give a community health worker who's linked to a NPO. Love Life is busy in some of the districts with their peer education program, both in metro and in rural, and we meet with the provincial coordinator twice per year, I think. And during the COVID, Love Life, Department of Education, and an NGO called The Cult, the EPWP, this group at least help also with the screening at schools to ensure that the educators are supported. Thank you. And I have, I'm not sure if Ms. Goliath would like to add from the Metro anything that I might have missed before we go to the questions. Through you, Madam Chair.
Thank you so much, Mr. Dumo. Ms. Goliath, is there anything that you would like to add from your side?
Good afternoon, Madam Chair. There's nothing further for me to add. Thank you.
Thank you so much. Minister, anything from your side? Nothing. All right, members, you may now kindly pose your questions. Mr. Dumo, can I ask that you please unshare your screen? Thank you. Thank you very much. Any questions from your side, members? No questions? Thank you so much, Mr. Dumo. It seems that you have satisfied.
Chair, you have not noticed my hand.
I just saw your hand coming up now, Member Botha. Kindly proceed. I could not see it on my side. My apologies, Member. Please proceed.
Thank you, Chairperson. I just want to check with regards to the outbreak support in the Karoo. I want to refer to Mandla Kosi Secondary School the Standing Committee on Education did a oversight visit there, and according to the acting principal, when the tests were done for COVID, not all learners were present on the day at the school. I just want to check with the department whether tracing has been done in regard to all those other learners who were not tested, and were all learners now as we speak tested for COVID? And then, Chair, in regard to the 3,595 eye test that was done, the slide indicated that 489 learners received spectacles. Now, the remaining of those tests that were done, did it mean that because only 489 received spectacles, that the others did not need spectacles, or were there just enough funding to for those 489 to receive a pair of spectacles? Thank you.
Thank you very much, Member Botha. I'm covered by your latter question. Any other member? Not? You can kindly proceed, Mr. Dumo.
No, my hand is up. I'm not sure if you see me.
I see it now. Please proceed, Member Tejo.
Yes, thanks, Chairperson. As far as the presentation is concerned, it's a very beautiful one, and it's a noble cause that has been pursued. And the only thing that I wanted to check, having noted the recent statement from the Premier of around about 40 learners in the southern suburbs who manage, or young people who managed to contract the virus recently in a teen bar. Now, noting that Love Life did embark on a sort of screening process in schools, that how far is this process of ensuring, because there was an anticipated second coming of the pandemic before the end of this year, learning that the learners are mostly back at school, even though they are doing rotational attendance. I just wanted to check that noting that Love Life program of screening at schools would have assisted a lot in checking those that are coming at school, that 19 schools were managed to be attended by the program itself. So how far is that in looking at curbing the curve again? Thank you very much.
Thank you very much, Member Tejo. Does that conclude the question round, members, I assume? Thank you very much. Member Botha, is that an old hand?
Now the hand is not even reflected from my side, Chair, so something is very wrong here.
Definitely so. Thank you very much, Member Botha. Ms. Siduma, please proceed.
Member Botha, yes, you are correct in saying maybe they didn't need. We screen as nurses, we screen with a sneller test on site, and then if it depends on the score, and then if the score dictates to us to refer you, it's only then that we refer you to the optometrist, and she or he will do the actual test. Now, some of the learners, it can be a borderline or a finding, or there might be something on that day that there's no need for spectacles at that moment. So that's the reason why we have more testing versus the issuing of spectacles. The outbreak and support is concerned that would happen in Kwamandenkosi. Because of the learners, not all of them going to school, and even if it's their day to go to school, they end up not going to school. So what we do contact tracing. So if we know that it is that grade or that school, so as far as possible, we will send our community health workers to go and do a tracing of those learners, and then the testing might happen at a primary health care facility or at a community-based center. But as far as this is concerned, the feedback that we receive is that it was dealt with successfully, but if there's any things that I will still just go and double check with the teams in Central Karoo to ensure that all the learners were reached. But as far as possible, the feedback that we got is that the outbreak was successfully managed. Before I go to Member Teko, maybe I should ask Shalon to say something about the two questions before I respond to the last question.
Thank you, Ms. Eugenia. Just a comment on the last question regarding the number of learners tested and the number of learners that is receiving spectacles. The explanation is correct that learners get screened and then more of thorough test gets done then to determine whether there is a true problem with the vision. But it's also a line, if you can see, it's almost 10%, the numbers, and that is what literature and evidence has also showed us, that there's a 10% of learners that actually gets tested that do require spectacles. Thank you.
Okay, going back to Member Nteku's question, Love Life, it's not available in all of our sub-districts, and neither is it available in all of our districts. Where they are active, that is where they helped with the screening of learners. And they are not active in all of the schools. They might be inactive in some of the schools, but not all of the schools. So the screening of learners, it's more of a partnership. What we can do, we do a little bit. What the Department of Education can do, they do a little bit, and any other NPOs that are able to help with the screening, they help with the screening, and then data is sent centrally so that we can report on the cases. I just hope I've answered your question. Thank you.
Can I
Mr.
just
Dumo,
add, Chair?
please
Can I add,
continue,
Chair?
Minister. Yes, please.
Okay.
Minister, can
Yes.
I kindly ask you to just limit your response to 5 minutes, please?
Yes, no, I was just going to say that, remember, there are other interventions that are happening in the school context, but not necessarily as part of the BAS. For example, the HPV, the vaccine for the girls to prevent cancer of the cervix. And also, there's also some immunization for boys and girls for, what do we call that vaccine? So it's part of that. So they are only presenting the specifics related to in the space of the COVID, plus also the part of the mobile, definition of mobile services. But some of these, as I've just mentioned now, for the reproductive and also some other vaccinations, they also fall under category, other category. Thank you, Chair.
Thank you very much, Minister Mbombo. If there's no further questions or follow-up questions, I also think that our time won't allow us at this stage. Then I also wish to extend my sincere thanks and gratitude on behalf of the committee to you, Mr. Dumo, Ms. Goliath, and the entire team that are responsible for the health services in collaboration, as you have mentioned at the very beginning. And thank you so much for availing yourselves today and presenting to this committee. Minister Mbombo, thank you as well to yourself and to your HOD and to the entire department for the sterling work that you do in the Western Cape. I will now excuse you very much.
Thank you,
Members,
Baba.
will you kindly stay on?
Thank you.
Thank you.
In order for us members just to deal with the following committee documents, Ms. Jamke, can I kindly ask you to put up the minutes for the 19th of August?
Can you see them, Chair, on the screen? Or there's nothing?
Not yet, not yet. We only see your folders, yes.
And now?
Yes, we can see. Members,
Chair,
page 1.
Can I ask first members to do resolutions on the meeting, then move to the adoption of the document, if it's fine by the members?
Okay, fine. Thank you, Ms. Jamke. Members, any resolutions from your side on the first presentation of EMS services? Member Tan?
Chair, I'm just checking with you, and the other members can help on this platform. Did you make a motion without notice for EMS staff recently? Because that's what I want to recommend in the light of the presentation.
Okay. I can vaguely remember, but we'll just make double sure. I think at the time that we were there already that we said we should convey that motion. If it was not done, we can certainly resolve that we do so.
Okay.
Thank you, Member Botha. Any other resolutions, members?
Chairperson, on the protocol, safety protocol, mobile services. Is it possible that...
Can I just stop you there? Sorry, Member Van Vogel, can I just stop you there quickly? Are we concluding with the one resolution on EMS services? On agreement, members? Thank you. Member Van Vogel, please proceed.
Safety protocol, mobile service chairperson, is it possible that the department can provide us with where they have this mobile of mobile clinics on farms, that type of relationship? Because they mentioned, I think the MEC as well of the department, one of the officials mentioned something that they are in partnership with certain farms where sisters and doctors, I don't know, of sisters were appointed. So if they can provide us with those details, I'm not sure, can it be part of our resolution, Chair?
We can certainly do so, Member Van Vogel. Your request is noted. Any other resolutions pertaining to EMS services, members?
None, Chair.
Member Bora, nothing from your side. Thank you, members. Members, then on the integrated school health program.
Chair, can I go?
Please, Member Bota.
I just want to request a progress report on the COVID outbreak at Mandla Kosi Secondary School in Beaufort West. If the department can furnish us with a progress report.
Thank you, Member Bota. Any other members? We will then conclude with the resolutions as posed by the members. Ms. Jamke, you do have that.
Yes, Chair.
Ms. Jamke,
Hi,
you
Chair.
are clear on the resolutions.
Yes.
Okay, thank you very much. Can we now proceed with the minutes of the 19th of August? Page 1. You can scroll. Are you happy with page 2, members? Ms. Jamke, can I just ask for clarity sake on the information requested? I see the time has elapsed for that information to be provided. Have we received the information?
The time in the dates, Chairperson, in the minutes, we can always amend it. I have not communicated this information to the department, but when I send the request of the committee to the department, of course, the date will change.
Okay, but I assume it should be done at the stage or at that meeting date soon after. So we have not submitted the request as in 4.1 and 4.2 yet.
No, Chair.
Okay, thank you, Ms. Jamke. Members, page 3. Are you happy that we can adopt the minutes?
Chair,
Member Botha?
I was going to raise the same thing that you have raised, but I'm happy to propose that we adopt with the amendments to those dates.
Thank you, Member Botha. There's a proposal to adopt the minutes with an amended date for information requests. Can I have a seconder?
Seconded, Chairperson.
Thank you, Member Allen. Can we now please proceed to the minutes of the 26th of August? We just see the folder at this stage. Nothing shared yet, Ms. Jamke.
Can you see, Chair?
Only your folder, not the document.
Gosh. Okay, let me.
Double click. Nothing yet. Are you managing on your side, Ms. Jamke?
Nothing still, Chair?
No, it only shows the folder and then there's a right mark next to it. But we can't see the document. Members, whilst Ms. Jamke is trying to retrieve the document, we have received the meeting documents also. Are you happy that we approve the minutes of the 26th?
Where's my folder now? I can't even get now.
I propose, Chair, to adopt.
I would second the proposal to adopt.
Thank you very much. And can I just kindly ask Ms. Jamke that we also follow up on the resolutions, whether that's finalized? And I think, members, it will also be very helpful that in future, perhaps, that we can have those documents requested or information requested attached to the minutes, just in order for us to have the whole package and be sure that we did receive the relevant information. Ms. Jamke, I think we can now, Member Botha proposed that we adopt the 26th August minutes, and Member Allen seconded. And then members, can we then move on to the committee report on the oversight visit conducted on the 2nd? Ms. Jamke?
I don't know.
We are now with the oversight report.
Yes, Chair, something is wrong with my screen. I'm trying. I can't even see the documents now.
Okay, no problem. I think we can proceed since we have received the documents. The 2nd of September, which was our oversight visit to Drakenstein Gouda Clinic and to the Worcester EMS members. Have you familiarized yourself with the document? I think there was just an amendment which I sent through to Ms. Jamke. The councillor mentioned is Councillor Colin Rains, and the community member is Mr. Roger Oorsen. Was there any amendments from your side, members?
No, Chair.
Nothing?
I don't know what happened.
Can I have a proposal for the amendment of this report?
Propose, Chair.
I second.
Thank you, Member Van Vogel and Member. Members, we are now with the oversight report as conducted on the 9th of September 2020 to the Klapmuts Clinic and to the TC Newman Hospital. We should also note that we also made some information requests on that day, but that information is still due by the 30th of October. So we'll still await that information. Ms. Jamke, we just need to ensure that we did convey that information request to the department, please. And also the committee agreed at that engagement that we will send a letter of gratitude to the TC Newman facility on the management of the hospital during this COVID-19 period. Are we happy to adopt that oversight report, members? Can I get a proposer, please?
I propose.
Seconded.
Thank you, Member Allen. And then our oversight report to the Red Cross Children's Hospital on the 16th of September. I can remember there was a motion expressed as was decided by the committee on the day. And there's also information outstanding, which is due on the 30th of this month. We also just need to follow up that we did convey that request to the department. Do we have a proposer to, or any amendments from members on that report?
I can't propose what's not there.
Can we have a proposer for the oversight report, members? The members that were present? Members, we are now dealing with the oversight report as we visited the facility on the 16th of September. Any proposer or any amendments to the report, members? Any member? I can remember Member Van Vogel being there. I think Member Allen was there as well. Members, please, you need to indicate whether we should adopt this report or whether you do have any amendments to this report.
Chair, can you hear me? Chair?
I can hear you now, Member Van Vogel.
I propose, Chairperson.
Thank you very much, Member Van Vogel. Seconded. Seconder for this report, members.
I can't second, Chair.
I understand, Member Botha. Is Member Allen still online?
Me too, Chair.
I am here, so sorry. I was just unmuting.
Thank you very much, members. You shouldn't be so slow to react, man. You got nice gifts. Thank you very much, members. Then we conclude with that report as proposed by Member Van Vogel and seconded by Member Allen. Ms. Jamke, the program, I think that's the last document. Is the draft committee program.
Is it on the screen, Chair?
Yes, thank you so much, Ms. Jamke. It is on the screen. Members, will you kindly have a look and give your inputs with regards to the program going ahead? Ms. Jamke, are we not able to be confirmed, especially the dates, according to the program, parliamentary program? I'm sure we can by now establish those dates.
For the dates, Chairperson, we will confirm them, but for the oversight visit to the West Coast, that is what I need the members, if it's possible today, to just give the dates as to when, because for the number of these facilities, I doubt if it will be possible for the committee to do this visit on a Wednesday from 9 to 12. So members need to take a decision as to how is the committee going to move forward in terms of this visit.
Members, Member Botha.
Chair, in regard to the 21st of October, that unannounced oversight visit, do we have a place where we are going already? Is it the Kailicha one that we missed out the other day?
Yes, that's correct, Member Botha.
Okay. Chair, I just want to send to you via the procedural officer some photos that I have received from a complainant regarding one of our health facilities in the metro. Just to put that also on the program at some point in time for an unannounced visit. But I'll send it to you after this meeting. I will send to Ms. Jamke and I will copy you in.
That will be much appreciated. Thank you so much, Member Botha.
And then in regard to the West Coast one, what did Namonde now ask in regard to that one? A date?
For members to determine a date, yes, since we won't be able to do it on a Wednesday during our normal slot from 9 to 12.
Okay. Does Namonde perhaps have the parliamentary program in front of her? What other slots can we use?
Chairperson,
Ms. Jamke.
Can I go ahead?
Please proceed.
If the members if the committee wants to do this visit to the West Coast, it needs to be outside the committee slot, it cannot be on a Wednesday. So it's either the committee members maybe follow your the way you have done yours, member Porter, and maybe members can sacrifice a week on the during the constituency week. There are 3 constituency weeks that are coming from Monday the 26th until Friday the 30th. That is the first week. The second week will be on Monday the 2nd of November until the 6th of November. And the third week is Monday the 9th of November until the 13th of November. So if the committee members are in agreement, maybe we can do a visit on the first week of the constituency week, or the second or the third. But let me put it on record that the second week already is going. The Standing Committee on Finance and Economic Development and Tourism will conduct an oversight during the second week of the cluster visit in George and Mossel Bay. They are doing their visit there. However, there is no clash in terms of our members. So the committee can decide which week you want to sacrifice out of your constituency to do this visit. Thank you.
Thank you, Ms. Jamke. Members, can I ask, since now I think it's quite evident that we won't be able to do it on a Wednesday during our normal slot, but looking at the facilities that we intend to visit, does it warrant an entire week? It doesn't seem like it has to be an entire week.
2 days.
What is your input, members? Member Botha and then Member Van Vogel.
Chair, for me also it doesn't warrant if I look at the places where we have to go, it's Vredenburg, Paternoster, Saldanha, they are all in few kilometers from each other, with the exception of Paternoster being a bit further away, but it could be done in one day. So I'm looking at the parliamentary program, and I am thinking the week of the 26th, why can't we use that Wednesday? October.
The 28th.
The 28th, yes, that Wednesday.
Thank you, Member Botha. Member Van Vogel. I thought I heard Member Van Vogel. Members, there is a proposal on the table that we schedule our visit for the 28th of October during the first week of constituency week. I think we can agree it doesn't warrant an entire week. So is it fine by members if we schedule that visit for the 28th of October as proposed by Member Botha?
Chair, just a point of clarity.
Member Van Vogel?
Yeah, Chairperson, I just need clarity. If you are saying the 28th, does it mean we will leave on the 28th of I just need clarity on that one.
We will just have to get guidance on the logistical possibility of also not rushing, but make sure that as we start off the day, we are able to visit the facility and perhaps not necessarily travel on that day. The coming back, I think, is fine, but we also need to consider the working hours of the officials and the overtime and all that. Ms. Jamke?
Chair, when I was saying that a week, I was not only referring to these facilities, I was referring to a case that maybe the committee also wants to visit other facilities around that area. That was the idea behind that, since the committee hardly get an opportunity to do visit outside the metro. So I thought that maybe the committee will be open in doing that. However, the Wednesday, the 28th is still fine. But now I'm not sure whether members want to leave on Tuesday afternoon and sleep on that side and wake up on Wednesday morning and do the visit. And I also need an indication whether these visits to the facilities are going to be an unannounced or an announced visit, because if they are announced, that means officials need to prepare presentation, and that can be time consuming at times. So that is the decision that I need from the members.
Yeah. Thank you very much, Ms. Jamke. Member Kego and then Member Botha.
Thanks. No, mine was to say, since the guidance from Unomonde, that if we can do maybe a 2-day visit, which means therefore if we can also identify other facilities that side. But the date that has been chosen by Member Botha, I fully support it. And then logistically, if we can leave a day before that, so that we'll be able to cover the uncovered ground. Thanks.
Thank you very much. Member Botha, was your hand up?
Yes, it was, Chair. Namonde has just brought me now nearer, and with Member Klego also. I would then revise my proposal, Chair, if we are going to populate and look at more health facilities. I would then say 1, do it all as unannounced visits. That's the one. And then I would then say, if we are going to want to do more than 1 day, let's then put aside that Wednesday and Thursday, which is the 28th and the 29th, or Tuesday, the 27th and the 28th, whichever, and then leave the late afternoon on the previous day. But then that would mean that we are going to then stay on the West Coast, or maybe, stay on the West Coast and do health facilities on the West Coast. Not then just those 3, but more than that 3, if we want to do it as more than just 1 day. That's just my amendment to the proposal, Chair.
Thank you very much, members, for your input. Members, can we then agree that we leave the afternoon of the 27th of October so that we can directly go into the business the morning of the 28th, and that we populate the program to make provision for more facilities? Perhaps we can even look at a public engagement as well on the West Coast, and then set out the 2 days, the 28th and the 29th. Can we see how that works? And also then communicate that with members, and then we amend accordingly. But the date set for now is then provisionally leaving the 27th and engaging the 28th and the 29th. Is that fine with members?
In order, Chair.
Thank you, Member Botha. Members, we are in agreement. Thank you. Namonde, you are clear with that?
Yes, Chair.
Thank you very much. And then we will also await the information that Member Botha will provide with regards to the facility that was brought under attention. Members, are there any additional comments from your side?
Just to say thanks for the briefing today.
I just wish to thank you so much, Member Botha. Members, thank you so much for your availability. Thank you so much for your valuable input, and thank you so much for your cooperation. And I wish you a lovely and a blessed day further. Thank you so much, Ms. Jamke, also for your support and our IT support on the side as well. Thank you so much, members. Keep well.
Just one last thing. On next week, Wednesday, the transport to Khayelitsha Hospital will depart at 8:30, not 8 o'clock. It's just around the corner. So members don't have to rush in the morning.
Okay.
Okay, thanks.
Thank you so much. Thank you so much, Ms. Jamke. Thank you, everyone. Keep well.
Bye-bye.
Bye-bye.